Sailburua eta lehendakaria funtzioetan, diputatu nagusia, DIPC-ko presidentea, agintariak, lagunok, arratsaldeon. It is a great honor for me to introduce Dr. Robert Langer, Institute Professor at the David H. Koch Institute of the prestigious MIT. He is one of the only 14 eminent scientists awarded by this highest and most distinguishing title by this institution. Ha recibido numerosos y destacados reconocimientos, entre los que se encuentran el Premio Príncipe de Asturias de Investigación Científica y Tecnológica 2008 o el Premio de Tecnología del Milenio 2008, considerado el Nobel de Tecnología. Pero quizás todavía resulte más sorprendente conocer que quien ha sido calificado como uno de los más prolíficos inventores en la historia de la medicina sea un ingeniero. Pionero y referente mundial de la liberación inteligente de fármacos y la ingeniería de tejidos, sus investigaciones descansan en un feliz matrimonio entre la biotecnología y la ciencia de materiales, que derivan en una auténtica revolución y una nueva forma de entender y afrontar con éxito grandes retos de la medicina. Robert Langerrek ingeniaritza kimikoko ikasketak egin zituen New York estatuko Ithaca hiriko Cornell Unibertsitatean. 1970 lizentziatu zen eta 1974 amaitu zuen doktoregoa Massachusettseko Teknologia Institutuan. Langer gazteak jendeari lagundu nahi zion eta medikuntza aukeratu zuen bere helburua betetzeko. Behin erabaki hartuta, kurrikuluma bidali zuen ospitale ugaritara. Denek ezezkoarekin erantzun bazioten ere, erokeriatzat hartzen zelako ingeniaria kimiko batek ospitale baten lan egitea. Lagun batek honako hau esan omen zion: Judak Folman izeneko batek gustukoa du bere kasa pentsatzen dakien jendea. Langerrek gutun bat bidali zion Folmakin eta honek aukera eskaini zion doktoratu ondoko egonaldi bat egiteko Bostongo haur ospitalean. Juda Folman, ameslariak, angiogenesiaren aurkitzaileak, uste osoa zuen disiplinen arteko elkar eraginean. Uste zuen, ingeniari kimiko bat pertsona egokia zitekela, beste ikuspegi bat emateko prestakuntza mediko hutsa zuten pertsonan lana osatzeko, eta bete-betean asmatu zuen. Robert Langer consiguió por primera vez el ansiado objetivo de aislar el inhibidor de la angiogénesis, trabajo que publicó en la revista Science. A continuación, diseñó un novedoso sistema polimérico para la distribución inteligente de fármacos por el cuerpo humano. En esta ocasión, el trabajo apareció en Nature. Era el comienzo de una brillantísima carrera de este eminente ingeniero al servicio de la salud humana. A pesar de los numerosos éxitos, Langer no se detiene y hoy continúa con la misma evolución de siempre. En la actualidad dirige en el MIT en su gran laboratorio biotecnológico con 100 científicos. Unos 200 antiguos estudiantes e investigadores de su laboratorio son hoy profesos en destacadas instituciones académicas de todo el mundo. Otros tantos han creado empresas biotecnológicas. Pero su tutela se extiende más allá de Boston. El presidente Barack Obama, tal como refleja en su libro Audacia de la Esperanza, le pidió asesoramiento sobre la investigación con células madre. El doctor Langer considera que los científicos son solo eslabones de una cadena y que una de sus misiones es, en palabras textuales, formar a los futuros biotecnólogos, a brillantes científicos que a su vez formen y asesoren a otros científicos. En definitiva, a este científico le apasiona compartir uno de los más preciosos tesoros de la humanidad, el conocimiento. Y hoy está aquí precisamente para eso, para compartir un conocimiento generado tras toda una vida entregada a la ciencia, en la que nunca ha faltado la pasión. Muchas gracias, doctor Langer. Bienvenido a San Sebastián. Bienvenido a Passion for Knowledge. Tiene usted la palabra.
thank you for that very kind introduction, and thank you so much for inviting me here to this beautiful city. I'm just tremendously honored to be speaking with some of the world's greatest scientists and to be speaking to all of you. I thought tonight I'll try to go over some of the work we've been doing on new biomaterials, but I thought since there are many young people in the audience, I might expand a little bit on the introduction and go over the question of how did an engineer get involved at all in a medical field. And to start, I thought I'd go back to when I was getting my doctoral degree in the 1970s. And I was getting my degree in chemical engineering. And nearly every one of my classmates in chemical engineering decided to go into the petrol industry to work for oil companies. And so I thought that's what I should do too. And so I had many interviews with these petrol companies. In fact, I received 20 job offers from different petrol companies. Exxon actually offered me 4. In fact, I think the only one that didn't offer me a job was British Petroleum. But one of the job interviews made quite an impression on me. I traveled to Exxon, and while I was there, one of the older engineers said to me that if I could just increase the yield of one of these petrochemicals by 0.01%, he said that would be wonderful because it would be worth billions of dollars. And I remember flying back home to Boston that day thinking to myself that I really don't want to do this. I started thinking about what I would do then. And one of the things that I was very excited about was chemistry education. I had helped start a school in Cambridge for poor children, and I got very involved in creating new chemistry curricula. One day, I saw an ad for an assistant professor to teach chemistry at a university. So I wrote them a letter applying for the job, but they didn't write me back. But I liked the idea, so I found other ads, and I think I wrote to about 30 different universities to do that, none of whom wrote back. So that wasn't going so well. But I was still very interested in using my chemical engineering background to help people in some way. So I thought about medicine. And as was mentioned, I applied then to many hospitals and medical schools. They didn't write back either. And then, as was mentioned, one of the people in the lab I was in said to me, he said, "Bob, there's a surgeon in Boston named Judah Folkman. He said sometimes he hires unusual people." He thought very highly of Dr. Folkman. I won't say what he thought of me. So I wrote to Dr. Folkman, and he was kind enough to offer me a job. And I went there. And I thought I'd start the talk by showing you a picture from the New York Times in 1971 of Dr. Folkman's concept of about how tumors grow. What he suggested was that a tumor cell somehow becomes abnormal, and then it grows to about 1 million cells, still small. But what would happen is that the cells on the outside would live, but the cells on the inside would die, because the cells on the inside can't get nutrition and cannot get rid of waste. However, what he proposed was that tumors could solve that problem by making a chemical signal which he called TAF. And what that would do was to signal to the surrounding blood vessels, which are normally not growing at all, but it would signal to them that they should start growing and feed the tumor. And when they do, that gives the tumor the nutrition. And then the tumor gets larger and larger and larger. It spreads through the blood vessels throughout the body, a process called metastasis, and eventually kills. Dr. Folkman said, if you could perhaps stop the tumor here, maybe you could make it small, and maybe the body itself might destroy it, and maybe other kinds of drugs might help it as well. It also occurred to us, as I'll go over, that it might not only be useful for treating cancer, but really any disease where blood vessels are abnormal. At any rate, how do you stop blood vessels from growing? No one had ever done that before. So what he and I talked about was that we have a tissue in our bodies, cartilage, it's in your nose, in your knee, and that tissue has no blood vessels. So I decided I should get some cartilage. And we started out by looking at the backs of baby rabbits, but they were very small, so I couldn't get much cartilage. So then I went to baby cows. And this is an early bone that we got. This is the bone part. This is the cartilage part. It actually doesn't come like this. When I would get it actually from what are called slaughterhouses, there was a lot of meat on it. So I spent a lot of my early career scraping meat off these bones. But when I did, that was the first step of the purification. And then I would cut these pieces off and put it through various types of biochemical purification steps. But I ran into another problem, which was, even though I had these different things that I wanted to test, how could you test something in the body to stop blood vessels from growing? And this is a very common problem in the medical field, the critical need for a bioassay. That was true for penicillin, true for many other things. Well, we needed to develop a bioassay, and none had been developed. So the assay we developed, we decided would be the eye of a rabbit. Here was our idea. The eye, or the cornea, also doesn't have background blood vessels, but it turns out if you put a tumor in the eye, as I'll show you shortly, it will cause blood vessels from the edge of this cornea to grow to the tumor over about a 2-month period. So what we wanted to do was to take the different things I isolated from cartilage and have some type of polymer, what we call a controlled release polymer, that we could put in the eye that would cause no damage to the eye, and yet that could deliver these molecules for, say, a 2-month period. Also, it was important, all these molecules in cartilage were fairly what we call large molecular weight, so it had to be able to deliver those over a long time. That also hadn't been done. And in fact, as would happen as time would go on, and I'll illustrate this later too, delivery of large molecules might be useful in areas other than just studying how blood vessels grow. Because if you tried to swallow a large molecule, you won't get it absorbed. If you try to take a large molecule in a patch, it won't go through the skin. If you inject a large molecule, it's destroyed very quickly. So for practical use of all these molecules that you might want to deliver on a chronic basis that were produced, say, by genetic engineering, which was also starting around the same time, you would need to have a way to deliver these substances in an unaltered form and yet protect them from harm. However, if one looked in the scientific literature in the 1970s, you would often see quotes like this. I'll read this to you. It says, "The agent to be released is a small molecule with a molecular weight no larger than a few hundred. One would not expect that macromolecules, for example proteins, could be released because of their extremely small permeation rates through polymers." Actually, the only positive thing that I had going for me is that I just didn't know that. In fact, this quote ended up being very helpful to us in getting some of our early patents. So I spent 2 years in the laboratory experimenting with many different techniques, and I actually found over 200 different ways to get this to not work. But eventually, I was able to make little microspheres like this. Here's one cut in half. In fact, today, this helped provide the early basis for a lot of what are called nanospheres in medical technology. But we created these, and we showed that you could release substances of almost any size from them for over 100 days. This was from that Nature paper that was mentioned in the introduction. We also showed later that you could get steady release. In 1976, I got asked for the first time in my life to give a talk at a scientific meeting. And I was very nervous about that talk. In fact, the only talk I'd actually given before this was when I was 13 years old in secondary school, just beginning. And there I had to give a minute-and-a-half talk, 90-second talk. So what I did is I wrote that talk out, and I stood in front of my parents' mirror for 4 hours reciting that talk. And the next day I got up in front of my 8th grade class, and I tried to give the talk. I didn't bring that sheet of paper up, but what happened was the first minute and 2 seconds, I recited it all right. But then I could not remember the next word. So I stood up there for another minute and said nothing, until my 8th grade teacher finally told me to sit down and gave me a very poor grade. I believe it was either an E or an F. So now, many years later, I had to give this talk, so I stopped work about 2 weeks in advance and kept going over this talk. And this was a 20-minute talk. And, of course, that was 34 years ago, so I was quite a lot younger. I had more hair. It was darker. And I was lecturing to a group of very distinguished chemists and chemical engineers. And I gave the 20-minute talk, and at the end of it, I felt I did all right. I didn't forget too much of what I was going to say. And so I thought when I was done, these older scientists, being nice people, would want to encourage me, this young scientist. But when I got done, a number of scientists came up to me and said, "We don't believe anything you just said." It was my introduction. Now, sometimes scientists treat other scientists. At any rate, by 3 years from then, other groups began to repeat it, and then the question shifted to why was this happening? To understand it, what we did is I would take techniques that were normally used in medicine, like pathology, and I'd use them to cut very thin sections through these plastic polymers. Here is a thin section of one of those plastics. Notice that substances 200 probably molecular weight or greater actually would not be able to go from one side to the other. But if we put in, say, a red drug, just to visualize it, and look at it before any release, what you see is polymer here and drug here. Now, say you release this for a year or two, and then you want to look and see what it looks like. And what you see is in sharp contrast to what you saw 2 slides ago. You see all these pores. And it turns out that these pores are interconnected. They also have very tight constrictions between them. And the pores are incredibly winding and tortuous. So it takes a really long time to get through them. You might think of this as like driving a car through Madrid. And by regulating these pore structures, we learned that we could make these systems last anywhere from days to years. And now we were in a position to address the angiogenesis problem. Here was the assay that I mentioned. Here's the tumor, and here is the polymer. And we had all these different materials that we wanted to test. So we actually tested over 1,000 rabbits, over 2,000 eyes. Almost all of them did not work. I like to think of those as the controls. However, I'll just show you one example. If you hear the tumor, this is about 7 weeks after the start of the experiment. The tumor's here, the edge of the cornea would be here, but notice how when there's not an effective substance in the polymer, which you can no longer see, blood vessels grow from the edge of the cornea over the polymer to the tumor. If you looked at this eye just 2 weeks later, it would be huge. The tumor would grow out of the orbit of the eye. We would sacrifice the animals before then. However, if you put this inhibitor in, the polymer, notice at the same time how the blood vessels are lower and they avoid it. And I'd say over 50% of these tumors never grow. This was the paper that we had published in Science that was mentioned in 1976 in the introduction. One of the things, however, that I've watched, unfortunately, in medicine is it takes a tremendously long time from making a finding to it actually being used clinically. So, as I mentioned, we published this in 1976. It took another 28 years and billions of dollars and really worked by many, many people at many, many companies before any of these were approved to be used for humans. But in 2004, the first one was approved, Avastin, which today is one of the largest biotech drugs in the world. Just about a number of months later, another approved, Tarceva. And you can now look down the list that there are many of these that have been approved, not only actually for different types of cancer, but also for one of the leading causes of blindness in the world, which is macular degeneration. That also has to do with blood vessels proliferating in the back of the eye. But it also occurred to us that this might not only be useful for, as I mentioned, these basic studies and isolating these inhibitors, but maybe it would be useful for helping various pharmaceuticals work better, be safer, and so forth. So we wanted to see, could we deliver some of these substances for long times as well? So here's a study that Larry Brown, one of our graduate students, did, just as a proof of principle, taking insulin, putting it in a diabetic rat. And what you see is normally the rat has a blood sugar of 400 if it's diabetic, but when you put this tiny little aspirin-sized pellet in, it lowers it to around normal for over 100 days. So once again, we wanted to see this get used. And here we did a number of things that were not just science. We actually created patents, licensed those patents to companies. I'd even get involved myself in helping some of these get started. And today there are many products based on these ideas that are being used clinically. For example, if one wanted to deliver a peptide to treat advanced prostate cancer, there are some very good drugs, but you can't swallow them, and if you inject them, they're destroyed right away. So they're put in little microspheres that originally you could inject once a month. Now you can inject once every 4 months. And this is now the most common way of treating advanced prostate cancer or endometriosis. Just as a second example, I wonder if many people here saw the movie A Beautiful Mind with Russell Crowe. I see some people. So the disease that Russell Crowe had in that movie was schizophrenia. He saw people who were not there. Does anybody recall how he was treated medically in the movie? He received shock treatment, electric shock treatment. Today, however, he might get this. This is an injection of these microspheres with a drug that Johnson & Johnson developed, Risperdal, in these little microspheres that lasts for several weeks and now is a very, very widely used way of treating this disease that has reduced suicides and hospitalizations. This one, recently approved, is a once-a-month injection to treat alcoholism. And there are many others that are being studied and hopefully will be approved as well. But you always want to think, what else can you do that can really change this field? And one day, I was watching a television show on how they made microchips in the computer industry. And while I watched this show, I thought to myself, this would be a very good way to make a drug delivery system. Now again, if you spent 35 years of your lives working on drug delivery systems, maybe any TV show you saw, you would think that. So, with one of my colleagues, Michael Sema, we made some prototype chips. But these chips were very different. Rather than just having electrical components, we decided we would put chemicals or drugs. This is a cutaway of a chip, and these are tiny little nanowells. And in these wells, you could put different doses of the same drug or different drugs. You could literally envision someday a pharmacy on a chip. Here's a picture of one of the early chips John Santini, one of our graduate students, made. There are 34 wells on the top, 34 on the bottom. Now actually we've made hundreds, and you can probably go to thousands. Here's just a little coin. By the way, these chips don't have to look like this. These are long and thin, but they can be made cylindrical. They can also be made out of all different kinds of materials. Let me just show you how they work. You have a cover, which might be made of gold or something else, and actually it will stay in the body for as long as you want, even years. But if you apply just a certain type of electric field to it, and you can actually do this by remote control, the way you'd open up a garage door, let me show you what happens. In 2 seconds, it starts to dissolve, and in 10 seconds it's gone. So whatever's underneath could come out. And here is just from a study we published in Nature showing that you can get different amounts of drug from different wells over different times. Here's another graph, more like this pharmacy on the chip, where we delivered several different drugs over different periods of time. And just to go over, and this is certainly many years ahead of us, because we haven't done this yet, but the type of thing that we have done on animals, I should say, but we envision that someday what you might do is you could actually have a totally programmed delivery, like you could just activate by remote control, telemetry, let's say, from a wristwatch or a BlackBerry, and you could program these to come off anytime you want. And sometime in the even further future, what you might envision is putting little biosensors on these chips that could detect signals in the body and then in response tell the chip how much drug to deliver. So far what I've done is I've told you how we might use engineering to take existing materials and make them do things they couldn't do before. But I also started wondering about the materials themselves. How did the materials find their way into medicine? Was it through chemists and chemical engineers? Well, it turns out almost all the time when I looked into this at the hospital, that the driving force for bringing materials into medicine were medical doctors who urgently wanted to solve a medical problem. And what they did is they would actually go to their house and find some object that would resemble the tissue or organ they were trying to fix. Let me give you a few examples. In 1967, some of the clinicians wanted to make an artificial heart. And they asked what object kind of has a good flex life, like a heart. And they said a lady's girdle. And they took the material in that and made the artificial heart out of that. But now, 43 years later, that's still what it's made out of. Because once you start down that path from like what I call a regulatory FDA standpoint, it's not very easy to change. The artificial heart has worked poorly. The biggest reason for that is that when blood hits the surface of the artificial heart, it can form a clot. The clot goes to the patient's brain, and they get a stroke, and they die. And yet, if you think about it, something that was designed to be a lady's girdle is probably not the best material to put in contact with blood. Dialysis tubing with sausage casing. Vascular graft, that's what's called an artificial blood vessel. That was a surgeon, actually in Texas, going to a clothes store to see what he could sew well with. And again, you can't make small diameter blood vessels. That's not been able to be achieved. Finally, breast implants. One was a lubricant. The other was actually a mattress stuffing. You can probably think of the logic. What we decided to do was, rather than take materials that already existed, we decided to ask the question, what do you really want in a biomaterial from an engineering standpoint, chemistry standpoint, and biology standpoint, and then could we synthesize them? When we started, the only material that existed that was safe to use in the body by places like the FDA were what are called polyesters. And they dissolve like this. They start out like this, the drug is in them, then they get spongy, and then they fall apart. And what this means is that if you had a potentially unsafe drug, even though it could be a good drug, but a drug like an anti-cancer drug or insulin, when it breaks up like that, all the drug could dump out. So that's not good. We said from an engineering standpoint, what you really want to do is get a polymer to dissolve like this, layer by layer. And we went through a very detailed, actually, chemistry and engineering analysis to figure out how to do this, to try to figure out what would be the right chemical bonds, what would be the right, what we call monomers. And I won't go through all of that, but maybe just to show you one formula. This is what we ended up with. We were very fortunate that I had some very good chemists and toxicologists like Michael Marletta, who would later become head of Berkeley's chemistry department, helping us. But basically what we found were two units, this one and this one. And they were connected by what are called anhydride bonds, and if you change the ratio of this to this, what you see is none of one of them, very, very slow polymer dissolving. It'll take 3 or 4 years for this to fully dissolve, even though it's very thin. But if you start adding more of the other one, you can make it dissolve in 2 weeks. So you could really change the ratios of those two units that I showed you and make these last from a few days to many years, or any time in between. So once again, we wanted to see if we could help people that were sick. And in this particular case, a young neurosurgeon named Henry Brem, who was just starting his career at Johns Hopkins, came to see me. And he was looking for a better way to treat brain cancer in its worst form, glioblastoma multiforme. And these are just some statistics in the 1980s. They've changed a little, but they're still pretty bad. This was when we started. And basically what you see is that even if you have surgery, radiation, and chemotherapy, you don't do well. Also, the drug that people generally used, BCNU or carmustine, for brain cancer is a terribly toxic drug. Usually it travels throughout the whole body, and that's why it gives you, as many chemotherapy drugs do, very, very bad side effects. So Henry and I had an idea. What if giving it throughout the whole body, what if we just gave it locally? What if we could do this? What if we could allow the neurosurgeon to operate on the patient, but before he closes the patient or she closes the patient, they line the surgical cavity with polymers containing this drug. Normally, the drug lasts 12 minutes, but we thought that if we put it in the polymer, it should be protected from degradation. So what the neurosurgeons wanted was a degradable polymer so it wouldn't accumulate in the brain, to have this surface degradation property so it couldn't dump all at once this potentially toxic drug. And from animal studies, they wanted it to last for a month. And finally, what they wanted is, and this is the idea of local chemotherapy, rather than give it throughout the entire body where it could cause harm, to give it locally where it could hopefully be most effective and least toxic. Now, in the United States, the way we do things is if you have an idea like a new polymer or almost any new idea, and you're working in medicine, you have to write a research grant. And then that research grant, in our case, goes to the National Institutes of Health. And they have study sections who are professors at other universities in the United States, review them, and tell you what they don't like, and decide whether you should get funding or not. And we did very poorly. I actually saved some of the reviews. I entitled this slide, "This Approach Will Not Work Because." In 1981, when we first proposed this, people didn't think you could synthesize these. But I had a very good graduate student named Howie Rosen, who later became president of the Alza Corporation, one of the most successful drug delivery companies in the world. They were purchased by Johnson & Johnson for $12 billion. And he, as a graduate student, synthesized these. And so we sent the grants back, and they said, well, you still shouldn't fund it because these polymers are highly reactive. They'll react with whatever you put in. But I had another couple of postdocs working with me, one who's now a very famous professor at Duke University and another very famous professor at RPI, and they did this in such a way that there was no reaction. The next issue was that, after we addressed this, was people said the polymers are fragile, they'll break. And I had another couple of postdocs, Avi Dome, who later became chairman of medicinal chemistry at Hebrew University, and Edith Mathiowicz, who's now a well-known professor at Brown University, and they made the polymers very strong. And then we sent it back again. They said, well, you know, people don't put new materials, new polymers in people. They'll certainly be toxic. But then I had a graduate student, Cato Lorenzen, who's now Dean of Medicine at a University of Connecticut in the United States, and he showed they were very, very safe. Anyhow, this kept going on until 1996, when they got approved by the FDA and other regulatory authorities. It was the first time in over 20 years the regulatory authorities approved a new treatment for brain cancer, and the first time they ever approved this idea of polymer-based local delivery. You can probably tell from the way I'm speaking that I'm very proud of how well all of our graduate students and postdocs did. They became chair people of major companies and very successful professors all over the world, whereas the reviewers haven't done so well. Now, I'd like to show you what this operation looks like, but I'm serious about this. If anybody is squeamish and does not like the sight of blood, you shouldn't look. But I'm going to show you human brains. Here's one with the wafer going in. Usually they put 6 or 7 in and close up the brain. You know, it's very difficult to get good advice when you give a lecture. But about 10 years ago, I was lecturing in Boston, and my wife came to my lecture. And I was lecturing to a group of engineers, which is what I am. And so I asked her at the end of the talk, I said, Laura, what did you think of the talk? So she said, Bob, the talk was all right. That's actually extremely high praise. But she said, I don't know if you realized it, but you had those 2 bloody slides on for 10 minutes where you explained every detail of the operation, and all those poor engineers were turning colors. So now what I do is do what I just did today and give people a warning. But for the chemists in the audience, I have to tell you the sequel to that story, which was that 2 years later, I got asked to give a dinner speech. But this was to a group of neurosurgeons. And I told them the exact same story and gave them the exact same warning. But at the end of the dinner speech, quite a few of the neurosurgeons came up to me and they said, those 2 bloody slides that you showed, they said those were fine. You could have left those on all night. They said, but those awful chemical formulas. So if you ever lecture to neurosurgeons, you have to make sure not to put up chemical formulas. It's a true story. There are various clinical trials that have been done. This was a very late-stage clinical trial in Europe which helped lead to FDA approval, and you get 31% in the treated group survived, 6% in the control. I think, well, what's important about this is not only would it lead to new treatments in cancer, and people are studying this in other types of cancer, but interestingly, it's also had a very major impact in the field of cardiology. Another one of my students, Elazar Edelman, as well as a number of companies, have tried to address the following problem. Today, if somebody has heart disease, one of the most common ways of treating a patient with heart disease is to put a stent, looking like that, into your blood vessel. A stent, the idea is that if you have your blood vessels clogged, this little metal design could prop it open. But at the same time, when you put these in, these also cause a lot of proliferation of what are called smooth muscle cells. And that can shut off the blood flow, and it could kill someone. At minimum, you'd have to be reoperated on. So today what they're using, and these are widely used, is they coat these blood vessels with a polymer, just like I showed you, put in an anti-cancer drug, like Taxol, just like I showed you, and that's had a remarkable effect of keeping these blood vessels open. We've also tried to think of other ways that materials can help. And so another idea that I once had, there's a whole area, I'll just go over it a little bit for those that aren't familiar with it, called minimally invasive surgery. It's really had a major impact on medicine. 30 years ago, if, say, one of you wanted to get your gallbladder removed and you went to the hospital and had surgery, they'd make a big incision in you and they'd take the gallbladder out. You would be in the hospital for several weeks to recover because of the big incision, and you wouldn't be back to work for several months. Today, they make a little incision in you, and they put these little, what are called scopes down the hole, and you can actually take the gallbladder out through that little hole, and you're out of the hospital in less than a day, back to work in less than a week. And they use this type of approach for many types of surgeries. So I was thinking one day that if you could take objects, even bulky objects, out through those holes, there's so many different medical devices that are bulky, could we ever put them in through those holes? Now that might sound like science fiction, but what I started thinking about was why couldn't we make materials that could be like a string at room temperature, so they could go in through the little hole, but when they got, say, to body temperature, they would just change into whatever shape we want. So I mentioned this to another one of my postdocs, Andreas Lendlein, and we decided to see if we could make some plastics that were degradable and compatible to do this. And I thought I'd show you a couple videos to illustrate some of what we did. So in the first video, what I want to show you is a string at room temperature, but then we're going to drop it into body temperature water, which is hotter, and hopefully it will change into a coil, like a stent. So let me try. Here's the string at room temperature air. We're dropping it into body temperature water. And it forms a coil like that. We could have programmed it into other shapes as well, like a sheet to prevent adhesions or other things. Let me give you a second example. Let's say you had a wound. You had a very bad cut on your arm or your face. What you would do is you'd go into the doctor and they might tie a surgical knot, a suture. It's not that hard to do if it's outside the body. I could even do it, even though you probably wouldn't want me to. But what if it's inside the body, like in your stomach or your lung? So we thought, what if we made the knots tie themselves? What if we looped in a loose knot at room temperature, like what we call in the U.S. a lasso, and then when it gets to body temperature, we'll make it tighten. So let me show you a second video where we'll look at this loose knot at room temperature air and drop it into body temperature water. So here's the loose knot. See how loose it is. We're going to drop it right into the water and see what happens. It just tightens. So these are what we call shape memory effects. We published actually one paper in Science showing how you could, in fact these videos are from that, showing how you could do this by temperature. We also actually worked out a way to do this by light. So you could shine a little fiber optic on it and also get it to change its shape. Well, the very last thing that I wanted to talk to you about today really relates to a problem of trying to create new tissues and organs. Here I've worked very closely with another surgeon, Jay Vacanti, who's now head of pediatric surgery at Massachusetts General Hospital. And a number of years ago, he was head of the liver transplant program at Boston Children's Hospital, where I also worked. And I think it was about 1982 or 83, he came to talk to me because he had patients like this little baby who's dying of liver failure. And the only way a child like that lives is somebody else dies and they would do a transplant. And he asked me, could we come up with a way to maybe use the patient's own cells or some relative cells so that someday maybe we would not have to do a transplant? So he and I came up with the following idea. This was from another paper in Science we wrote, where theoretically, and this is just a schematic diagram, you could take any cell type. These are bone, cartilage, liver, and so forth. Interestingly, if you take these cells and inject them at random, not much happens. But a number of research groups, not our own, but a number of research groups have shown that these cells are actually quite intelligent. And that if you put them close enough together, that in some cases they can reform structures. So we thought, what if we made polymers that could be three-dimensional, where the cells could be close enough together, and we set this up in such a way to make these tissues or organs. We also, and this is a key issue, have to grow them the right way, and then maybe we could do the transplant. Also, I'm sure all of you have heard of stem cells, and that actually could be very useful because having a good cell source for any of these is critical, and stem cells could be a very, very good cell source. Just to show you some pictures of these scaffolds. This is a scanning electron micrograph of one of them with liver cells on it. Also, we thought many years from now, what you might be able to do is even use computers to help design different body parts. So another one of my postdocs, Prasad Shastri, used computer-aided design to help make some different scaffolds. I'll just pick the nose as an example. Here he made a nose, which actually is challenging in that it's 98% air, and the rest, this polymer that you want to put cells on. Now here, it's kind of like a regular nose. But I would guess 40 or 50 years from now, let's say somebody wants to go to a plastic surgeon, and you could probably look on a screen and pick out any shape nose you want. So let's say somebody would like their nose turned up a little bit, an upturned nose. You just take a little bit off here. Let's say that somebody wanted what we call a hook nose. You probably wouldn't, but if you did, we would just give a little more polymer here. And then, as I'll illustrate shortly, you could actually take the patient's own cells, so they wouldn't reject, and put them on these scaffolds. So I thought I'd end this talk by giving you 3 examples of this type of thing. In the first case, I will give you cartilage. This is work we did with Chuck Vacanti, where we took cartilage and we made new cartilage on nude mice. And again, if you're using or nude rats, and if you're going to use the patient's own cells, you shouldn't get rejection. So here, this guy's head got redone, just as a proof of principle. Here, his cheek. If you open the animals up and look at it, it's pure cartilage. And by using what's called histology, it really looks almost like textbook cartilage. But what happens is it's not strong enough to solve some serious problems, like if somebody's a runner, we're not able to solve that problem yet. Yet there are many problems that are more cosmetic in nature that you actually can solve. One of those problems we're working on the United States Army with. And that is, sadly, when soldiers come back from Iraq or Afghanistan, sometimes they miss different body parts. Sometimes they've actually missed an ear. So Linda Griffith, who was one of my postdocs, made a scaffold in the form of a human ear. Here's a high-powered close-up of just a tiny part of it using what's called a scanning electron microscope, where you see the polymer fibers, which will ultimately degrade, the cartilage cells, and the cartilage matrix. And over time, these will totally degrade, and it will be filled in by this. And hopefully you could make an ear. And to prove that, it's not yet been done on patients. We believe it will be done in the next 2 years, but with some of the soldiers. But Chuck has done this on rabbits. And here's a rabbit with the human ear. And sometimes people think, why do you do it on rabbits? But the reason we do is because we really want to know that it's safe to use on human beings. And we actually have done that. There's actually been a number of situations where some of the clinicians we work with have operated on patients, and I'll give you this little boy as an example, to really help them and help their lives. They're done under what are called physician-sponsored INDs. In this particular case, there's a 12-year-old boy. But if you look at him closely, he has no chest covering his heart. And in the United States, a lot of 12-year-old boys like to play what's called baseball. But you could imagine if he ever got hit in the chest with a hard baseball, he could die. So my colleague Jay operated on him, took his own cells, and we made a polymer scaffold for him and made him a new chest. And he's now doing fine years later. The second example I want to give you is new skin. This actually from a company that licensed this from us. And this is actually now approved by regulatory authorities. But let me just show you an example. Here's a little boy who's very badly burned. But you can take the scaffold and take what are called neonatal fibroblasts, human fibroblasts, and you can actually freeze these under the right conditions. And then when the child is burned, you can put them on like this. This is when he was burned. But if you come back 3 weeks later, he looks like this. And if you come back 6 months later, he looks like this. So this has now been approved for patients that are burned and patients with diabetic skin ulcers. The very last example that I want to go over is still being studied in animals, but I wanted to share with you a little bit about what we're doing. In this case, Aaron Levick, one of my graduate students who's now a professor at Case Western Reserve, asked, well, could we ever apply these kinds of things to people who are paralyzed? Could we make a scaffold that through engineering you might take the outer part and orient it in such a way, actually using some nano patterning approaches, that you might help what are called axonal guidance. And then in the inner part, could you put what we call neuronal stem cells? Here's a picture. This is the scaffold. Here's the inner part, which is porous, and you put the stem cells. And here's the outer part. And what was done in these experiments is to take a section of the spinal cord out. And what that will do, as I'll show you in a second, is it will make the rats paraplegic. They will have difficulty moving their hind limbs. So we did this, Evan Snyder and Ted Tang, who's a neurosurgeon, to 50 different animals and followed them for over a year, 400 days. And in all of the control groups, they did poorly. And I'll just show you a video of the mean of the control group. This is 100 days after the start of the operation. There's really two things I would draw your attention to. One is he's having difficulty moving his hind legs, and the second are the paws. They're sort of placed in an awkward fashion. And we'll just look at this for a few more seconds, but you'll see the idea. So we did 37 controls, 3 different groups, and then we did 13 treated animals. And let me show you the mean now of the treated animals, which is not a cure by any means, but it is, as you'll see, a significant improvement. So here's one of the treated animals, like I said, the mean, not our best or our worst, but the important things to notice are that this animal is able to bear his own weight. And also, if you look at the paws, they're splayed in a much more normal way. Like he's walking a bit awkwardly, so it's no cure by any means. But the bearing the weight and the paws. My wife told me not to leave that on too long either. So I want to just bring you up to date. And so we showed this pretty repeatedly on rats, but to bring something to humans is a great deal of work. So in the last several years, we've worked with a number of spine surgeons to try to develop a primate model. And we really tried to do exactly the same thing, exactly the same experiment, to see if it would work in primates. And while this work is early, we've now done about 8 different monkeys for about 10 weeks. The results are almost parallel, and I thought I would show, though we used a slightly different test. So what I thought I would show you to end the talk is putting these monkeys on a treadmill. And what you'll see on these videos is first the control where one of the legs is paralyzed, and then the experiment where we've put the material and stem cell implant. So here is a typical what we call control. This is the leg that he is having trouble moving. We're going to do the same thing to these animals, but we'll put this stem cell polymer implant in, and notice he's doing better. Again, not a cure, but a big improvement. And like I say, these should still be viewed as preliminary because we have more to do. Let me just show you one other set. This is at a little longer time. Again, he's having trouble moving this leg on the treadmill. And now we'll look at this one doing, again, quite a bit better. So, again, a long ways to go on this. Anytime you start, as I've gone over, medicine takes a long time, and when you try to move from these basic chemical ideas that we're putting forth all the way through test tubes to small animals to large animals to people, it takes many, many years. But to me, it's just such an important thing. It's a way of using chemistry, chemical engineering, and material science to create new things that can relieve suffering and prolong life. I want to just thank you so much again for inviting me here. It's been an absolute honor to share this with you. Thank you. Can we do questions?
There'll be no questions.
Oh, no problem. Okay, I kept it to 15. It started at 6:30, so that's fine. No, that's fine.
Okay. Over that way. Gure programa luzatzen denez, ez da galderarik izango gaurko